So let me start and open the meeting. And first and for all, I would like to wish you hearty welcome. Thanks a lot for your presence. Thanks a lot for your time, your availability, and your active participation. So my name is Marc Biot. I'm the regional coordinator for MSF Access Europe and MENA region. But I have the pleasure here indeed to be present to really launch this reflection and the sharing of experiences of many of our colleagues around the problem of accessing TB medicines in Europe. As a matter of fact, so we will have a panel discussion first where we have our guest speakers. So MSF will present its own experience coming from our work in Poland, and which then we take, I would say, a step backward and indeed recognize a European problem. We will then also be preceded by Denis, who will bring a patient perspective. Jaime from the Salud por Derecho organization will explain what he has faced helping Spanish patients to access TB medicines. And then also we have our colleagues from DG HERA who will come and present their trials and their positioning. And we have, of course, also an esteemed member of the European Parliament who will be present as well to listen and to participate with his own reflections, guidance, and suggestions to way forward. We will then have also an open discussion where all questions can be formulated for clarity and or for further policy reflections. And I invite everybody here in the room to actively participate, as well as the people online. And we have over 100 participants, hopefully online, I don't see now, but at least we had more than 150 people registered. So, and we indeed also invite everybody to participate actively. Shaylee is in contact online, and so she will also highlight if you want to say something, please raise your hand online. And also, if you want to share important information on the chat, she will scanning the chat as well. Everything that we as MSF will present is also in our brief document report that highlights problems and an analysis of where the obstacles are and provides recommendations. These, I think all of you have been able to access online, but if you want to have also a hard copy, it is here in the room, and we can provide many more. So we printed out also many more copies, and so please ask us to have more copies for distributing around with colleagues, clinicians, patients, associations. We definitely will be very happy to forward these hard copies to everybody. And I would like now to ask Rory, our moderator, to launch the discussion. Thank you, Rory.
Hello, everyone. Thanks very much, Mark. You're very welcome here in Brussels and online. My name's Rory O'Neill. I'm a health reporter at Politico. And I'm very pleased to have been asked to moderate this panel on access to tuberculosis treatments. TB is a preventable and curable condition, but remains a significant public health threat across the world, including in Europe. Vulnerable populations struggle to access the treatments they need, particularly for drug-resistant strains, which are a significant challenge in the WHO's Europe region. To help me understand why that is, why access remains an issue, we have, pleased to say, a top panel of experts from government and civil society to outline how Europe can secure access to TB medicines. So I'll introduce them in the order they're speaking. We've got Denis Godlewski, who's a TB survivor and regional coordinator at the International Treatment Preparedness Coalition. We have Joanna Ladermiszka, who's the medical coordinator for MSF in Poland, with 17 years of humanitarian experience across the world. Very pleased to, we also have Jaime Manzano, Research and Advocacy Manager at the Right to Health Foundation in Spain. He's a pharmacist by training and currently works on access to medicines and migration policy. We are delighted to be joined by Katarzyna Motyka, Policy Officer at DG HERA, that's the European Commission's Health Emergency Preparedness and Response Authority. and very pleased to have been joined by MEP Vytenis Andriukaitis. He's a former EU Health Commissioner and a member of the European Parliament and also a member of the Parliament's Health Committee. So each speaker is going to have about 10 minutes initially to outline their perspective before we go to a Q&A, where we'll take questions both here in the room and online. For those of you joining us online, feel free to submit your questions through the chat if you can, and we'll try to get to as many people as possible. Dennis, if you'd like to kick us off, you're more than welcome to stand here at the lectern or stay at the seat. Totally up to you.
Yeah, it's okay if I sit because I don't want to, be over the crowd too much with my height. It's hard to say from my looks now that I once had TB and weighted 50 kilos, but it was the case with the same height. And I come originally from Russia. That's where I got my TB. Now for several years I live here in EU. Before I start with my story, because my role today is like from personal perspective, but also from professional to share some of the experiences that people have. But before I start, I would like to thank my colleagues who are hopefully online, who helped me also to prepare for today's session, from TB Europe Coalition, from TB People, the communities organizations and organizations that help migrants across EU, for bringing together some cases that I'm going to talk about. And to start off with the personal story, I often say that I had TB and I was lucky because my TB was drug susceptible. So it was an easy case, but even in that easy case, in Eastern Europe, the system managed to fail because I had to move during the period when I was taking treatment from one city to another, they forgot to cancel my treatment in time. So instead of the proper 9 months of treatment back in the days, I took my anti-TB treatment for the first round for 2 years straight. So they basically forgot to cancel it, which was quite an experience with some side effects, as you can probably imagine. And it helped me later, once my organization started to work more on access to TB in Eastern Europe and Central Asia, and now as we see the situation here in the EU, to see how easily a person can fall in the cracks in the system, which can be very simple as a human factor, but can be very systematic. And human stories that me and my colleagues have gathered when preparing to this event, they also illustrate some real-life barriers that people face. And surprisingly, when you work in countries that are non-EU members of Eastern Europe or in Central Asia, you quite often refer to the EU from the outside as an excellence case, unlike US, because like US and healthcare, basically you die if you are there and you don't have a health insurance, right? So in EU, you have this assumption that if you are in EU, you are protected, you will get your treatment irresponsible of what is your status. But unfortunately, we see that sometimes right now, 3 years after the full-scale invasion of Russia started to Ukraine and the new wave of migration from Eastern Europe that we see, we were not able to address here in EU all of the problems and all of the difficulties, which I think this document perfectly showcases. I think this table, this chart, when I looked at it first, it's something that you really don't expect to see when you speak about EU and medications, the registration status of the drugs. So drugs not registered, drug is not registered, drugs, something that you often see in Central Asian countries. And you hear from pharmaceutical companies that these are very small markets, there are no money in these markets. But you think EU, it's a big market, it's nice prices for pharmaceutical companies to have, so why the drugs are not registered? And we see that in many cases, the guidelines are already there. For example, the drug rifampicin, which is a very key drug for people living with HIV, for TB preventive treatment. WHO now recommends this drug as a part of the prevention that person can take 3 months, just 3 months, instead of like a longer 6 months or a year, which is very hard to get people to eat additional pill for 1 year, especially when you are a person living with HIV and you are already on a lifetime treatment, right? So this drug is not available, and there are several companies who have the ability to register, but they don't, and EMA doesn't have like a very strong stand on it, and there is no encouragement to actually bring these companies to this market, which is very needed. And it's just one example, because if you look at this chart, like almost every third or second drug in this chart has this problem, access barrier as drug not registered. So this is the first thing I wanted to speak. And second, the second very important point I wanted to mention also from the systematic point of view, because the personal cases that we have gathered, cases when people encountered stigma or they were not given the proper treatment, or they were not properly diagnosed or dealt with by the workers in the centers for asylum seekers, or the people who had to be mandatorily replaced, and some other cases when people were not able to get treatment without insurance because there were no mechanism in the given EU country. I don't want to, point fingers at specific countries, but to try to look at it from the bigger perspective. So all these systems, in many cases, all these problems, they were successfully resolved by community organizations and non-for-profit organizations, such as MSF, such as organizations on the ground, grassroots communities, and so on. But we are now in the year of unprecedented healthcare crisis. And the first to see the problem were those non-for-profit organizations, because most of the organizations faced the drastic reduction of funding, drastic reduction of staff. People had to fire their community workers. They had to stop their community-led projects because they didn't have the support for this. And it happens now. And it shows to me the fragility of the whole response that we have, because if we don't have organizations on the ground that are able to solve these cases, to help, to bring people by hand, to accompany them through the system, and the system is not ready with solutions 3 years after we faced on this crisis and we have been able to identify those barriers, then basically our response now is very fragile. Let's imagine the situation. I don't want to, predict anything and hope it won't happen, but let's say MSF is not there, or WHO, which has already reduced its capacity by a third, faces further reductions. What's going to happen next year? So I believe what MSF has done and what colleagues will be talking about, and what this report, this document talks about, are the systemic solutions that are needed essentially, and as soon as possible. They need to be implemented in place to make sure that our response and the TB situation in EU is addressed adequately and in a sustainable way. That's where I'm going to stop for now, to pass it to colleagues.
Thank you so much. Thanks very much. And Joanna, I'll hand it over to you. Would you prefer to come up here? Yeah, sure.
So good afternoon, everybody. Thank you very much for coming. I will then, from the perception of MSF, through our experience in Poland, I will speak about what we saw ourselves and how we tried to document it through our report. So maybe first, our intervention in Poland has been based on the war in Ukraine. So if you look to the numbers that are in this table, comparing the TB cases that just before the war started in 2021 were present in Europe, so the whole European Union, then in Poland and Ukraine, you can see the big difference between the numbers specifically when we speak about drug resistance TB. So it's this form which is much more complicated to be treated, and it was in the Ukraine more than 12 times that in the whole European Union. So at that moment, WHO made some estimation based on the refugees that were officially registered in Poland. So specifically, if you look again to this drug-resistant form of tuberculosis, so Poland was supposed to receive over 200 refugees that needed continuation of this treatment. And it's more than 4 times that usually Poland had in 1 year. So as we started our intervention, trying to assure the continuity of treatment that those persons needed, so we start being confronted by different barriers, and those were really systemic barriers. So first, Poland at that moment didn't have really a system. So it was very localized situation. It means that each hospital actually was confronted with a different way of dealing with TB cases. And then Poland didn't have any specific resources or any specific strategy towards TB. In terms of diagnosis, at that moment, Poland didn't have yet targeted diagnosis, so it was very complicated path for a patient to reach actually a medical structure. As well, Poland was not using this very fast molecular testing that can diagnose TB just in a matter of few hours. The people had to wait several weeks to be properly diagnosed, and sometimes they were not diagnosed completely. So actually, the resistance profile was not checked, and they were starting directly on drug sensitivity treatment. At that moment as well, everybody had to be treated in the hospital. So for the drug-resistant cases, some people needed to stay even 2 years, so the entire duration of the treatment, and even in complete isolation. And at that moment, TB was kind of forgotten disease, which means that there was little awareness, and as well it was a strong stigma. We have to say that somehow we become the victims of our success, because TB was very present in the 50s, in the 60s, and then Poland really had a very successful TB program, which really decreased number of cases, and this is why it became a forgotten disease. In terms of medicines, we didn't have the medicines on the ground to initiate or continue the treatment specifically for drug-resistant TB. So Poland at that moment didn't have those new medicines which are much more, let's say, adapted to, so first they are much more effective and they are much less toxic. At that moment, Poland was still using the older regimen, which are less effective and much more toxic. We had as well almost no fixed dose combinations. So in Poland, a person with drug-sensitive TB has to take at least 11 tablets a day, which should not be more than 3 or 4 per day. We had nothing for children, so no pediatric formulations, and we didn't have these medicines that Denis already mentioned, this rifampicin, which is crucial for preventive treatment. So at that moment, Poland had really outdated guidelines, so not including these new regimens that are much more effective. And then with time, we realized that the barriers that we saw in Poland, which was availability of the medicines, so simply medicines were not there, or the affordability, so the ones which we could find, they were very expensive, that was not only a Polish problem, it was really a European issue. So as a consequence of the situation, we are in a place where we have a system which is not very accessible, or it's not really adapted to the needs of the patients. So we have a late diagnosis, so we have increased transmission, and this is why we see a lot of really complex cases. And let's not forget that a TB which is not treated, a person with TB which is not treated, can infect around 10 and 15 people per year. So later we diagnose people, more cases we can have. And then, of course, if we don't have proper medicine, we have a high risk of amplifying resistance. So TB is becoming more and more difficult to be treated. So somehow we discover a situation in Poland and in European Union, which somehow is disconnected from the achievements that has been made in the last decade in TB, which for me, who has been treating TB, for example, in India 10 years ago, it was quite shocking being working in my own country. So we started our project that started in 2022, and we just finished it at the end of September. And it has been a very successful story. So from our perspective, we were able to support, because our main project was to support the patients from administrative, social, legal, but as well educational perspective. So linking them to care and sustaining them over the treatment. So we were able to support almost 340 patients, from whom majority had this complicated drug resistance tuberculosis. We were able to provide very fast needed medicines on the ground. Poland used flexibility mechanism to accept this donation. Poland today is implementing the best regimen for drug resistance TB, so they have national guideline for that. They implemented ambulatory care for drug resistance TB, so the people can be treated fully at home. We created this cross-border mechanism because we know people, especially the migrants, they are moving between the countries, so we are able to connect them to continue the treatment in different countries. And then, of course, TB today, it's much more visible in Poland, and it has been a lot of capacity building activities. It has been really a joint project. So Ministry of Health in Poland acted directly and very fast. They created, let's say, legal framework by making a pilot project for drug resistance TB, through which all those activities were possible. And what's happening now, it's really the turning point, because up to December, Poland is defining its own TB strategy, the first one after the 60s. So it's really a major, major step forward. What has been done in terms of access to TB medicines? Poland managed to negotiate super well the price. So when we speak about this regimen, it's extremely expensive, but Poland managed to decrease the price by negotiating directly with the companies, and it's almost 40% of the price. So 2 days, this important regimen cost around 28,000 euros instead of 45,000, but even this 28,000 is actually 100 times more than it cost in the low and middle income country. So you can see in this table the comparison between the prices that more or less the European countries pay and the prices that you can get if you buy it through a global drug facility mechanism, and the prices that the TB programs in the low and middle income countries are paying. So through this experience, we decided to really document what we see, to try to really understand where are the barriers, why we don't have the access for this essential treatment, not only in Poland, but in the whole European Union. We tried to find out as well all different ongoing initiatives that could be used. And we tried to define recommendations at national level, but as well EU regional level. And this is the document that you have now in hands, and you will find as well in the access, this is in the annex, what Dennis mentioned, that medicines by medicines, they status on registration status is mentioned and analyzed. So I will be just going through very briefly of those recommendations. You will find all of them in the document, but as well my colleagues will be actually mentioning many of them. So now looking at the national level. So first, what each country should do to update the TB guideline, because it's really the base for the rest of the machine to move towards correct treatments. Then they need to improve this whole coordination, because we realize in Poland, the departments do not speak between themselves. So they need really to increase their collaboration. We need really centralized system for the medicines. So before in Poland, each hospital was buying. So it's really fragmented system. And if we think later on to have a pool procurement, first, each country really needs to centralize their own system. We need to use as well regulatory flexibility. All of the countries, they can import non-registered medicines. The flexibility mechanism exists and they can be used. And Poland used them to accept the donation. We need to promote price transparency. This is as well essential if we want to negotiate the prices, and we should really go for the pooling or joint procurement. And each country should show more leadership to try at EU Council to move forward this difficult topic of access to medicines. Now let's look to the regional level and let's look for each barriers that we were able to identify. So first, it's really this limited awareness. So majority of the countries think, okay, TB, it's the story of the past. We don't have TB. Well, we do have TB and we need to address. So this is why we need HERA and SONTE to recognize TB as a key public health issue, because it is a public health issue. And we need as well for it to integrate TB into the AMR. So antibiotic resistance already recognized in European Union as a priority. And when we speak about TB, we speak about antibiotics, because all this combination of medicines, the combination of antibiotics. The second barrier, we are a super small market. So companies are not interested. So how can we change that? We need to pool our demands. We need to increase the demands. Regulatory system, it's not properly adapted to this kind of public health issues that have very small demand of the medicines, but they are very crucial because we speak about infectious diseases. So here again, the same case for all the antibiotics as it is for tuberculosis. So we really would like EMA to explore regulatory solutions to fast track. We really would like as well the WHO pre-qualification system to be recognized in European Union. It's a system that has been working super well for the last years. Millions of people are treated with the medicines that are WHO pre-qualified. We as MSF in many countries, we are people with HIV, with TB that use the medicines that are WHO pre-qualified. In Europe, we do not recognize this mechanism. And then of course, we need some amendment for pharmaceutical legislation. We need to adapt our Critical Medicines Act, and we need to include TB in our EU medical countermeasure strategy. It is an infectious disease, and we should think about it in that way. So the last barrier, the monopolies and the lack of transparency. So at regional level, we should really promote the mechanism on the prices transparency. We need to challenge secondary patent. One of these crucial medicines that is in this regimen is bedaquiline, which is not covered by patent in low and middle income countries, but it is under secondary patent in European Union, so we should address these issues. And we have as well to be conscious that as European Union or as other separate country, we actually invest public money and research and development of those medicines. So somehow we are investing money and then those medicines are then too expensive for us. So we really need more transparency on that. So as our motto, medicines and tests should never be a luxury. And thank you very much for your attention.
Thanks so much, Joanna. And I'm going to hand it over next to Jaime Manzano from the Right to Health Foundation.
Actually, I suggest the other panelists, if you want to take a seat, it would be easier for the presentation. Can I use the controller? Okay. Yeah, fantastic. So I will be picking up on some of the topics that my colleagues have already presented. Well, first of all, my name is Jaime Manzano. I'm a research and advocacy manager of Salud por Derecho, which is a CSO based in Madrid, Spain. And I would like to start with you looking at the picture of the frame that it's over there. And it's because access to tuberculosis in the European Union, it's a very nice example of a very hot topic today in global health, which is the framing and reframing of the area. A frame, as you can see there, can highlight what's within the frame in terms of content, color, shapes, but it also creates a different effect that it's prevent us to focus on what's outside the edge. Global health works in very much the same way as a frame, and this is an idea that has been originally developed by one of my colleagues at Salud por Derecho, Adrián Alonso. And traditional framings within global health decides at the end what's within that frame, and actually who and what counts. So it decides how policies are formulated and how injustice are created. And there is a level of injustice that it's even deeper than that, and that's what Nancy Fraser has called misframing. And that's when the frames are taken for granted and they are drawn so narrowly that entire populations are outside that frame, and we cannot question why. And that's exactly where tuberculosis sits right now in the European Union. As Rory had said, it's a preventable, curable disease that we have decided to let it be our deadliest. And what we're seeing in Europe, and what I'm showing you now that we are seeing in Spain, isn't a problem of the past, as John Green quoted in his best-selling book. It's a reminder that of very old barriers that are well known for all of us that works in pharmaceutical policies. That is high prices, monopolies, lack of transparency, lack of safeguards to public interest. And tuberculosis is the quintessential misframing that represents a new paradox in global health, which is that now rich countries cannot access global innovations they have invested in. And this is not just a trend that we're seeing in TV, that we're seeing also in HIV with long-acting PrEP. And at the end, what I want you to walk through my presentation is to widen that frame and to understand why we should consider what the problem that we're having regionally and locally as a global health issue, and to connect it with different struggles that are happening around the world. That vintage posters from the Biblioteca Histórica of University of Salamanca, Historic Library of Salamanca University from the early 20th century, it says that 40,000 people die annually of tuberculosis, and luckily we are not there anymore, at least in Spain, but we are not where we should be. I'm going to use the exact same format of MSF report to walk you through a Spain situation. This is a number of evidence that we have been collecting through freedom of information requests to the Spanish government, as well through desk research and informal conversation with TV advocates in Europe. And here I want to highlight also that for me, the most added value of the MSF report that you guys have in hand is that it gives you also a new frame to understand tuberculosis within the European Union and EEA. So this is a super quick overview that won't stay much. This is the situation in Spain. Spain is a low incidence, low mortality, low MDR cases that have seen the same dynamics as in the rest of Europe, that since 2022 there is a consolidation of a slowdown of the decrease that we saw since 2015, and we are seeing an increasing notification in locally acquired TB cases. Since there has been progress, that's a reality, not as fast as we should have done it, and you can see that we are not hitting the NTB targets, not for 2025, not for 2030. And that's a problem, and that's something that we should be looking also when talking about tuberculosis and access to drugs. Let's take these three elements of the frame that MSF has provided us with as report and take the BPAL regimen in Spain to see how that's not only a combination of drugs, but an illustrative example of inequities within a so-called universal healthcare system. So in this slide, you can see the list prices for the BPAL regimen in Spain that show us a combination of barriers. First of all, a barrier of unaffordability, which is, of course, the high cost of new medicines. Both bedaquiline and pretomanic, which are the newest medicines of the regimen, represent the majority of the cost, which is over 57,000 euros per patient for a 6-month full course. But also the small drug that you see over there, linezolid, which is a pretty old drug that has been reimbursed in the Spanish health system since 2001, represents 10% of the cost of this treatment, when, as my colleague has shown, it can be purchased by much lower prices in low and middle income countries. And here, what we need to look at is that these are artificial high prices. What does it mean artificial? First of all, these prices do not represent R&D costs. As we have seen in some independent investigation, public investments in bedaquiline surpasses private investment by some order of magnitude. An analysis of cost of goods and production cost show us that bedaquiline can be produced by 0.25 cents of dollar per day, which is not what we are paying now in Spain. And secondly, they are artificial because they are list prices. These are the public prices that we managed to get, but these are not the real prices. Real prices are maintained confidential. Our authorities, the Ministry of Health, sign non-disclosure agreements with the companies, so they can always have a high list price, high public price. So when other countries reference to the Spanish price, this is external reference pricing, they will get a high inflated price, and so negotiation power will decrease for these countries. So we have everything here, high prices, transparency, and how a local problem connects to the global arena. This is a comparison of the bedaquiline price is the previous one, not the updated one, but we can see how the Spain list price is higher by hundreds of times for each drug. But that's affordability is not the only barrier to access. Non-availability is also a barrier to access. And what do we mean by non-availability? For instance, this other important drug of the BPAL regimen does not have a commercialization status in Spain. That means that that's approved by the EMA, but it's not commercialized. It hasn't been approved for public reimbursement, and the company hasn't required the government to do so. When this happens, what we see is that hospitals need to do a special pathway to order that. It's called the Access to Drugs in Exceptional Circumstances pathway. That means that for each patient, you need to do one medical report. That means one pile of paperwork, additional time, additional burden for hospital staff to develop that, another lack of access for TB drugs. We have another dimension of a lack of access, which is the time that passes since the drug is centrally authorized until it's included in public reimbursement. For the case of bedaquiline, it's only available since 2022 in Spain, and I'm pretty sure that's the case for some other countries. So all that regulatory void, all the desert that it's in the middle, that's a violation of the right to innovation for many patients that cannot access the highest degree of innovation that is available for treating their TB. It's not only a problem of the BPAL regimen. The Lamanid shows the same price. What you can get it from the Global Drug Facility for 57 euro, you have a Spanish list price of over 1,000 euro for the same drug. And this happened also in a number of drugs. And here's when it comes the interesting part, because I'm not only going to talk about problems, but briefly about potential solutions that the Spanish case offers us. First of all, both of my previous colleagues have mentioned the case of rifampicin. And for the case of Spain, is particularly ironically, because some of the trials that have been done to get this shortened treatments for rifampicin were done within the TBTC, where Barcelona is the only European center. So Declaration of Helsinki, like how the patients benefit for the products of these trials. They do not. It's not registered in the European Union, it's not commercialized in Spain. A well-known problem from everyone, the ongoing global shortage of rifampicin-based products. Some evidence in Spain points that these kind of shortages affect half of patients, and my colleagues have already explained that this might lead to the risk of monotherapy, that might lead to the risk of resistances. And when we look at the different shortages that we have seen in Spain during the past year, we can see that the median is way higher than the median that we see for some other drugs. Again, this is a problem of antimicrobial resistance that is not being addressed. And this leads us to one good thing that we have seen in the Spanish case, that is that we didn't have the pediatric formulation and child-friendly formulation, but do a physician that's also a TB advocate, Tom Noguera. He managed to get the regulatory authorities to cooperate and order those drugs from the Global Drug Facility. The Global Drug Facility that normally serves low and middle income countries was used by Spain to get these drugs at very low prices. And that's also something that could be extrapolated to the problem we've just seen of the global shortage, because consolidation of demand, when happened at the highest degree possible, so from local to regional to global, creates more stable markets and more solid supply chains. So, finally, and I'm happy to go into some of the recommendations, but just for the sake of being brief, what we're asking to our government. So our critical medicine list has the very same problems that the European one that the colleagues from MSF have noted in the report, and is that not all drugs that are essential to treat tuberculosis are collected in this list. Actually, 86% of the drugs that the MSF report mentioned in the annex are not present in the Spanish critical med list. Second of all, we have already said pool procurement at all levels. Pool it nationally, pool it regionally, pool it globally. At national level, we already have framework agreements in place. They have been used for immunosuppressants, biosimilars, neonatology equipment, bringing savings, bringing predictable supply. One thing of doing this is continue the collaboration that has stopped with the GDF because they are not longer providing pediatric formulations to Spain. Transparency, because we have seen that when the prices are not the real ones, it impacts the whole world, not just Spain, and it makes it very difficult for other countries to negotiate their price, but also for accountability on what we're doing with public money. Conditionalities, the pharmaceutical companies do have in Europe already received huge amounts of public money. Sanofi, who is the company responsible for register rifampicin here and hasn't done that, does receive money from the Med4Cure programs, from French credits, so on and so forth. Why not using those moments where we are giving public money away to ask for something in return? This is a conversation for the next MFF, for the FP10, for Horizon, and any other contract that has to be done. And finally, funding. Funding not only for national programs, but funding for international programs, Stop TB Partnership, United Global Fund, all the actors, global health initiatives that are working on this, and funding for civil society and communities. Without advocacy, this won't move forward. And finally, we have to understand this within a universalism perspective. That is, it has to be for everyone, no matter if they are in rich countries or poor countries. All these recommendations apply for everyone so that no one is left behind. Thanks a lot.
Thank you very much. And next up, we have Katarzyna from DG Hera. And I think we have one more PowerPoint, if I'm not mistaken. So I'm going to keep my seat in the front row. But... All right. Okay, over to you, Katarzyna.
Okay, thank you. First of all, thank you for organizing and thank you for having us here. I'm going to present the joint procurement mechanism at EU level that we conduct at HERA and try to answer the question how this mechanism can address the shortages of TB medicines, if this is even possible. So the joint procurement agreement was signed in 2014, and its main goal is to procure medical countermeasures against serious cross-border health threats. It has, as of now, 38 participating countries, so the scope is much wider than just the EU 27. And its main goal is to ensure more equitable access to medicines, to improve preparedness against health crises, to improve security of supply, and it also aims to enhance the negotiation capacity by joining all forces together. It is a complementary tool for national procurements. It is voluntary, so we cannot impose anything on countries, and it's also non-exclusive, so meaning that countries can have their own bilateral contracts. The entire procedure is currently conducted at HERA. The money to finance those medical countermeasures come from national budgets, so there is no involvement in principle of EU money. And we apply EU procurement rules. We are bound by the EU financial regulations, and we need 4 countries to come to us telling us we need this particular medical countermeasure to be able to start the process. We also do have already some success stories with the joint procurement that has been used on the EU level. So during the COVID-19 crisis, we have purchased equipment and medicines, and that was more than 200 contracts. We have not purchased the vaccines under the joint procurement mechanism. That was another mechanism. And after the COVID-19 pandemic, now we are in the preparedness phase, and we have more than 70 contracts in place for vaccines, mostly Mpox vaccine, pre-pandemic, zoonotic influenza, pandemic influenza, COVID-19, and we have secured by now millions of doses of those vaccines to the European patients. So it works. Now the question is, can it work with tuberculosis? We don't have the answers yet, but I can tell you, I can present what we have done so far at HERA. In 2023, the Commission published the communication on shortages, and with the aim to improve access and availability of antibiotics. We have held numerous consultations with different stakeholders, with the European Medicines Agency, with WHO Euro, with MSF here, with ECDC and JAMRAI. And we established a task force composed of 12 countries, not just EU member states. And the purpose of this task force was to identify the gaps and the obstacles in accessibility of those drugs, and to pre-select 2-3 antibiotics that would be suitable candidates for the potential joint procurement. This has been done. The candidates, suitable identified candidates were pretomanid and bedaquiline, which have been already mentioned here as a part of this BPALM regimen by WHO. Both of drugs are authorized at the EU level, and both drugs are for drug-resistant tuberculosis. Over the summer, we've had discussions with both marketing authorization holders, so with Viatris and Johnson & Johnson. And Viatris initially was open to the joint procurement. They presented pretomanid to the joint procurement countries last month. Johnson & Johnson, after some discussions, declined to participate, claiming that they do not see an issue of access of bedaquiline in the European Union. And now what do we do now, and what are the next steps? And we are consulting within the task force and other stakeholders, and we will keep discussing with Beatrice the potential JP for Bretonmanite. And I've listed some challenges that we face, but most of it has been already mentioned before by Björn and Heimi, because we have identified the same issues. So it's significant variability in access among countries. This is linked that some countries, the Baltic countries, can access those two drugs via GDF. The rest of the EU countries cannot. This is also linked to a very high cost, because this has also been said already, they are very expensive, and the prices vary between the European countries significantly. There are also high marketing costs, also mentioned, that brings some additional and substantial costs to the companies. The patient name basis procedure that is used in most of the countries to access those drugs is not always very effective and timely, and there is additional obstacle that in some countries the practitioners are hesitant to use it because they're concerned over liability. And also mentioned the diverse reimbursement mechanisms. This vary tremendously on EU level, even on regional level sometimes, because in some countries procurement is done by the regions or by hospitals, so and this is linked to reimbursement as well. So just to sum up, we think that joint procurement is a very useful tool, but it's by no means a one-size-fits-all solution. It has to be also underlined. And the cooperation with companies that we so far had over the course of those last few months has been at times challenging. But nevertheless, we still believe that it might be an idea to use it. So that would be it from me. Thank you.
Thank you so much, and very pleased to hand over to our final speaker before the Q&A, MEP Vytenis Andriukaitis. Would you like the lectern, or are you okay there? Perfect.
Colleagues, thank you very much indeed. You saw in 2014 started with joint procurement.
Just a little bit closer.
Microphone is here, is okay? Yeah. Okay. I feel very comfortable in this conference. Now, because first of all, definition, Medicine Sans Frontiers, or Doctors Without Borders, in one hand, and another, we have borders in our mentality, because every time you can repeat mantra, healthcare is member states' competence. Old mantra, member states' competence. If you look into Lisbon Treaty, you can find only one single line when they're speaking about cross-border healthcare threats. It means then we have shared competences. And it allows us now to have regulation on cross-border healthcare threats. Many, many years ago, it was decision. And you know it very well, decision on cross-border health threats. And you know that we had a Health Security Committee, a very weak one. Now we have here. But at that time, when I was commissioner, it was Health Security Committee. And of course, we raised a question several times. If something will happen, for example, if something, epidemics or pandemics, what can we do? Can we have our tools, which should be described as shared competences at EU level? Or only cross-border healthcare threats are now shared competence. And of course, you just mentioned situation about voluntary cooperation in public. Why not mandatory? And of course, then question about drug-resistant tuberculosis. It was on my table from 2014 to 2019.
And we spoke a lot about drug resistance tuberculosis, and figures show that it is close to the border, eastern borders, Lithuania, Poland, Slovakia, Hungary, because it's border with Belarus and with Ukraine. And then after war, for me, it was obvious that we will see multi-drug tuberculosis in much broader picture. Why? Because it is absolutely, we are not prepared to address those issues. Of course, tuberculosis, if you look into your picture in Spanish time, if you look into 19th century, the main killer was tuberculosis. And now globally, tuberculosis is main killer globally. Not malaria, tuberculosis. If you look into statistics from WHO side, you can see that tuberculosis is still high on the agenda. But if you look into situation about treatments, about vaccination, I am a member of TB vaccine initiative. You know, we're just trying to push forward ideas to develop new vaccines against tuberculosis, because new vaccines, this requires a lot of efforts, but still we are far from BCG vaccine was developed when? 60 years ago. And now we're still in the same situation, and treatment is very old one. And of course, you just raised absolutely clearly, you know, main problems. Improving availability, affordability of medicines, okay. Streamlining regulatory pathways, okay. Fostering stronger cooperation among member states. Fostering stronger cooperation among member states. How can we foster cooperation among member states if you just show that approaches are very between different member states? They have no appetite to cooperate. In some countries you have appetite to cooperate, some not. Some forgot about tuberculosis. I already argued about HIV, hepatitis C, and tuberculosis, because this is complex, it's together. HIV, tuberculosis, and hepatitis are complex. And we argue about necessity to improve vaccination and so on. But the main obstacles are, and now Medicine Sans Frontiers, you are thinking globally. And you are thinking about EU as one entity. But it doesn't exist. You have 27 different healthcare systems, 27 different reimbursement and systems, and of course, appetite to cooperate is very low. Now you coined definition, European Health Union. European Health, you know the definition. European Health Union. It was high on the agenda in 2019, yes, 2020. 2022 was very high on the agenda, European Health Union. We can propose to build first building blocks of European Health Union. Yes? What was first building blocks? Crisis preparedness and management at HERA, one. Second, pharmaceutical strategy, pharmaceutical package. Third one, long-term care strategy. Fourth one, it was comprehensive approach on mental health. And fifth one was, I forgot. It was called first building blocks of European Health Union. Now, where is European Health Union on the political agenda? Going down. State of EU, in the state of the EU, health was mentioned in very narrow approach. It means that when we are arguing about necessity to strengthen, to access, to cooperate, to promote, and to encourage member states to cooperate in area of healthcare and care, what we see? No appetite. Can you imagine? Now we are just fostering stronger cooperation among member states. It means that we need to invite ministers of health together in Brussels and to discuss those issues. My question is, do you know how many times ministers of health are gathering in Brussels per year? per half a year one time, sometimes 2 times per year. One formal council and one informal. Why? Because no appetite. Because it's not shared competences. If you compare agriculture and healthcare, you see that in agriculture you have 12 times per year ministers are gathering in Brussels, or sometimes much more. Ministers of economy or finance, much more. Ministers of health, 1, 2, and you are arguing about necessity to strengthen, to foster cooperation among members. How can we do it? Only on voluntary basis. My question is simple. Are we capable to raise questions about European health union? Because a union requires what? To have much more shared competences. When I was commissioner for health and food safety, in my hands, in food safety, I had per year 2 billion euros in food safety and 75 million euros in public health. Can you imagine these proportions? And you are arguing about necessity to press commission to do, they have no tools. Tools are enshrined in our mind. We need to understand now it's time to rethink what does it mean, European Health Union, in front of infectious diseases, in front of challenges, in front of climate change, in front of all threats around us. My answer is simple. We need to think about much more shared competencies, because a union requires shared competencies. Customs union, shared competencies. Single market, shared competencies. A digital union, defense union, economic and financial union. In every file you can find a lot of shared competencies. When you are speaking of European Health Union, voluntary cooperation, mainly voluntary. And then you argue that we need to improve availability and affordability. Okay. Then we need to streamline regulatory pathways. Okay. Who is against? Who is against? But why are not doing it? When I am a member of European Parliament now, it's my first and last mandate, because I am, was elected, surprisingly I was elected. But I can tell you, my goal is to say health should be as an aim of European Union policies also, not as an ancillary issue, because now health is an ancillary issue, and you are doing. I have no ideas to see. Please do something more. No, you do excellent job. You do what you can, because you have no chance to do more. But I am the same animal from the Commission, I am the same animal, it is for me political animal. I have no chance to attack Commission. I am just defending Commission, because you presented excellent situation, which tools are, and you are asking more. But more we can ask for whom? Member States. But member states have no appetite to cooperate. Only when war was striked, and in Poland now you see much biggest, numbers of drug-resistant tuberculosis. Of course, look into streets now. How many homeless people in Brussels? For sure they have tuberculosis. For sure. I am a medical doctor. I practice 27 years in practice. For sure, please, absolutely, crystal clear. In Brussels you can find, but nobody is detecting. And we are living in such environment, and sometimes you can, of course, what we need once again, streamline regulation, pathways, and so on, enhance cooperation. But it is my open speech today. We need to raise very clearly. We need to have more shared competencies at EU level, as in food safety the same. In food safety, we have excellent system, local, national, regional, and global. And we have a lot of tools. And we manage food safety, and now food safety standards are in every country, and nobody is arguing that food safety is national competence. When you are speaking about treatment, medicine, about pooling resources, about possibilities, no, national competence. Why? It's absolutely crazy situation. We are now without frontiers. Doctors are without frontiers, but national thinking mentality is with frontiers, silo mentality, national competence. It's old, it's very, it's old narrative. It's very old, like to say, paradigm. We need to change this paradigm. And tuberculosis is a good example when we can say, look, here is threats. We need to use shared competences and need to go in more obligatory way, in more mandatory participation and more mandatory cooperation, not creating something centralized. No, mandatory cooperation. And then we can change situation, addressing all challenges which are just excellent presented to you. Thanks a lot.
Thank you very, very much. Thank you so much to MEP Andriukaitis and all of our panelists for their presentations. We're going to go to the Q&A section. So just a reminder for those of you joining us online, please feel free to ask your questions in the chat. Shaylee from MSF is going to help me out with taking questions online, and of course we'll take questions in the room as well. If it's okay, I have one to start the discussion. Katarzyna, I wanted to ask you about, it was a very interesting presentation. What jumped out at me was what you were saying about Johnson & Johnson declining to enter into joint procurement talks over bedaquiline. I think you said their position was that there aren't access issues in the EU. What would your response be to that? I mean, could you outline for us why was bedaquiline selected as a target for joint procurement, and how would you respond to their contention that there aren't access challenges here?
Does it work? Yeah. So bedaquiline was selected by the task force because, first of all, I mean, and the task force, this is TB experts from the countries that we've gathered together, and we target particularly those two because there is this new regimen treatment. There are numerous access issues, and the access, as I said, is different in different countries for bedaquiline and different for predominate, because there's two different drugs and two different companies and two different marketing situations also on the market. But they are also EMA authorized, so that's why we targeted them, because for us also from practical reasons, it is a bit less challenging to go for monopoly situation in a market situation when there is a negotiated procedure. And this issue that you just tackled, that the companies are saying that there is no access issue, because most of them are saying this. So this is where the opinions or the situation vary, depends who you ask. This is that's the stance, I think, for the moment. But of course, there's the situation with predominate is I think a little bit worse than with bedaquiline, but that doesn't mean that there are no access issues. Thank you.
Does that work? Super. Do any of our other panelists have an opinion on Johnson & Johnson's position, and particularly their claim that there are no access issues in the EU? If anyone wants to jump in on that.
Maybe just from my perspective, I think it's in advantage of pharmaceutical company to keep a fragmented system, because then they can negotiate with each country separately. So I think it's just simply that. that's not in their advantage.
Yep.
From the stories we hear on the ground, there are definitely problems with access to bedaquiline for people, like if we look at it from the end user perspective. And also, I think it's a very surprising situation that, again, if you look at Central Asian countries, many of Eastern European countries like Ukraine, they have access to the Global Drug Facility GDF price over their catalog, which means they're paying what is now $68 for the treatment. And just to highlight, those were developed for the taxpayers' money already, which was shown by colleagues many times, EU taxpayers' money including. So we're paying like twice right now. It's the second time we're paying. There is definitely a ground for negotiations, both with Johnson & Johnson for bedaquiline and also with TB Alliance for pretomanid. And TB Alliance, I want to highlight, it's actually the non-for-profit organization. That's in their statute, that they are non-for-profit organization. They act in many instances as a full-scale pharmaceutical company, which is very unfortunate to see, hindering access by also doing patenting in Eastern European, Central Asian countries, I suppose in EU as well. So there is definitely a ground for negotiations, both for J&J and for Viatris and TB Alliance.
And finally, just to point out that due to the work of ITPC, the Medicine Affordable Medicines Campaign, but also I believe MSF, Johnson & Johnson dropped his secondary patents in low and middle income countries while keeping them in the EU until 2027. There was clearly an access barriers in lower and middle income countries. Why not dropping the patents here? Of course, they know they have access barriers here, and they are proactively maintaining them.
I think on no borders issues, TB doesn't know borders. TB doesn't, like HIV, like hepatitis, there are no borders for infectious diseases. Why are we putting the artificial borders like patents?
No, it's simplification of situation. Of course, we know very well viruses have no borders. Yes. Oh, just now it's okay. You know, viruses no borders, no borders. Bacteria knows no borders. It's mantra. But why borders exist? Because different economic models and different reimbursement models, different countries, different appetites, and pharmaceutical companies, they are not charity, companies. They are producing medicines because they see return and so on, and they are playing globally, and they have a lot of it. Of course, we need to change regulatory frame. Of course, you need to change, pharmaceutical package maybe, and more. Of course, you need to change Critical Medicines Act, and of course, once again, we need to change a situation with insurance, with reimbursement systems. It requires a lot of efforts. In EU, you have 5 models of reimbursement, different Bismarck model, beverage model, Mediterranean model, Central European model, and to find solutions, only one way is to press very much European Parliament and countries. If we are speaking about the infectious diseases do not know borders, means we need to create much more harmonized mechanisms in every member state responding to those issues. Patents also a very complicated situation. It's not so like that. It's impossible to solve like that. But of course, with very complicated situation, and from my point of view, we need now, as never before, to discuss, especially now keeping in hands Critical Medicines Act, pharmaceutical package, to find new regulatory pathways which allow member states to oblige member states to cooperate in more effective way, to pool share, as you just presented, pooling resources and so on. Only one way. And it's a lot of, we can, solve those problems, but it's very complex one. We need to discuss those issues in a very comprehensive manner.
Just going to check. We have questions online.
Yeah, there are a couple of questions for Hera. One is from Tiziana. Can this joint procurement mechanism be applied to unregistered drugs? And second question from Yannicka is, would a TB joint procurement only be open to countries who opted to join the task force? And can Hera indicate who is engaging so far? What alternatives does Hera have when a manufacturer does not wish to participate? Is Hera considering exploring joint procurements for other TB drugs discussed today, example rifapentine and fixed dose combinations?
Okay, that was a lot of questions. So first, if you can repeat them one by one, and I will address them one by one. I try.
Sorry. Can this JP mechanism be applied to unregistered drugs?
Yes, it can, but they have to have a clear regulatory pathway for registration in the EU. But it's not an obstacle to make a joint procurement for an unregistered drug.
Thanks. Would a TB joint procurement be open to countries who opted to join the task force? And can Hera indicate who is engaging so far?
Okay, of course, no, it will be open to all 38 participating countries. So the task force was only to establish what do we need, what are the gaps, what are the obstacles. Gathering 12 countries was easier than 38, and it was voluntary, so this is how we did that, but the joint procurement would be open to all country signatories of the joint procurement agreement, which is this 38 countries. And then the next question was?
What alternatives does Hera have when a manufacturer does not wish to participate, for instance, like J&J and Viatris in this case, I guess?
No.
Is Hera considering exploring joint procurement for other TB drugs, rifapentine, FDCs?
We have had discussions, especially about rifapentine and rifampicin. We discussed with EMA the situation on the market with Sanofi, but for the moment, and also for rifampicin, which was also identified like one of the potential candidates, but we opted for pretomanid and badaquilin because they're EU authorized, as I said. But so we see all of that, but for the moment, I think we don't have resources also for this. So we are just 6 people in the joint procurement team in Hera. So yeah, so we have to prioritize a little bit, but we see that.
Thanks. Now, there are a few more questions. Whoever wants to take it for all panelists. Another one from Yannicka. Which of the barriers discussed today can or have to be solved at the national level versus at the regional/EU level?
I think we have to look at it as there's not one from the other one. So somehow the process needs to start at the member states level, and we just heard that. So it's a lot that really can be done at the member states level. So for example, each country can independently use flexibility mechanism to import non-registered medicine. As a starting point as well, each country really needs to make their own guideline, which will be the base to know, which medicines are really needed, and to have the centralized system of management of the medicines for tuberculosis in terms of purchase, but as well the distribution, because the first step before going for the HERA pool procurement we need first that each country, they have their own centralized system. It's not that a hospital from Germany or another hospital from Poland will ask separately. So they really need first to have their central system. But then all those mechanisms that exist, so Critical Medicine Act, it's happening at European level. It needs to be addressing TB. AMR initiatives, it's European level. The whole pharma legislation review, it's EU level. So there are really different, one cannot exist from another. So two solutions at national level, so member states, but as well those mechanisms that already exist should be used. And all of this is clearly as well defined in our report, where for each barrier we see what has to be done at national level and what has to be done at EU level.
Just to briefly comment, that's a measure we have available in Europe that is rarely mentioned for European Union, but is widely mentioned for other countries. And we do have compulsory meanings. We have compulsory license that could be issued. We had an EU-wide compulsory license recently negotiated. We have compulsory license that could be done at national level, and that legislation should adapt to make them real with, the barriers that we know that exist with data market exclusivity nowadays.
I'm just going to check if we have any questions here in the room. Yep.
Paul Sommerfeld, I'm from TB Europe Coalition. I'm speaking here with a sense of frustration that I really pick up the point just made about need for action at national level. And I believe that we, civil society, that's where we should be the most effective. But we don't have the funds to have the people to do the work. In TB Europe Coalition, I've got a small secretariat living off grants for particular projects. I don't have any money to put to this, yet I believe that we could and should be collaborating much more closely at the national level and begin, it's great to hear Jaime talk about what's really happening in Spain. We don't have that, the somebody like Jaime and Salud por Derecho in each of the other even major EU countries, let alone some of the smaller ones. I'm not sure if anybody can really respond to that frustration, but putting it as a question, it's how can we in civil society collaborate rather more strongly than we do at the moment on these access issues? Thank you.
If I may, you know that a lot of civil societies now, they are looking into your budget, into a new budget, because you are depending on grants from European Union side. And now you know that a reduction in financial lines is a very big one. And as you know, for example, Europe is beating cancer. It was dedicated 4.3 billion euros to this plan, but cuts in the budget is about 1 billion. And now all organizations argue that they have no possibilities to achieve grants from European Commission side because very limited resources. And now if you look into proposals for new MFF is so big, 2 trillion euros. It's compared to challenges around us, unbelievably big. But member states have no appetite to deliver, their promise to have more effective budget. You can raise question, how can you, make your voice be heard? Only one way, political way. We need to encourage NGOs and organizations to be more vocal about necessity to have much more financial support to your existence. Otherwise, you have no chance to, you have only one small secretariat, that's all. I know very well. A lot of organizations, they have very small secretariats, and they are now in very difficult situation. Only one way: raise questions, press European Parliament, press Commission, press Member States government that we need to have much bigger budget. Otherwise, it would be disaster.
Yeah.
Maybe also to add, in addition to building coalition and being more vocal in, like, you know, signing on things together and stuff like that, in addition to budget reductions, what some of my colleagues have also told me that in one of the recent messages received by those who received the grants supported by you, by European Commission, was that you cannot use the funds received within this grant to actually target the politicians within the EU. So I see people nodding in the audience, so probably you were also hearing about these recommendations, which I understand the political background about, and I understand like the precautions and security measures why it was introduced. But at the same time, if we cannot use the EU money we get as a grant to target the EU politicians at the national level to, you know, be better in responding to our health needs, then basically we were having a problem, like in a very simple words.
Dennis, you almost touch for me on something which I could get equally passionate about, which is the way in which at the moment the European Commission has not been accepting and approving the operating grants it used to give for voluntary organizations. It went through my own organization, but it's mirrored by many others, went through a whole process of putting forward a budget, having it approved some months ago, but still we do not hear if that money will ever flow, and it looks increasingly likely that it never will. So in other words, the assistance to voluntary organizations, NGOs, is much reduced. So that's another block, let alone the particular one you've just raised, about how political one can be. But it is yet I would love to work, you know, MSF is doing a wonderful job, but I would love to work with MSF units in the different countries and say, you know, France in particular, I don't know any agency in France, civil society agency, that is really interested in TB and as a major issue, but would love to try to push the French government more, at least when France has a government. Anyway, sorry, I'll stop on that note.
We had one more hand at the back.
Yes, it's a question. I mean, in the level of the European Union, we have ECDC, who has a role mainly in surveillance, which is, of course, very interesting. ECDC does also a lot of surveys about the availability of TB drugs in the country, because several countries alarmed ECDC about that issues. And it's true, ECDC doesn't have an operational role, so maybe we should extend a little bit the competence of ECDC, who works through national focal point in each country. So it's certainly possible in the EU level to have a coordinated action between countries to alarm the Ministry of Health, and that they organize several meetings per year on that issue, because it's not only bedaquiline, pretomanie, it's rifampicin. Now in Belgium, we have again a shortage for rifampicin, and we start also with pyrazinamide. So we have, I don't know how we say that, levier to do things, ECDC among other, and I think we should use this levier as well.
It's a very good question, though I might have to ask our panelists to respond briefly.
If I may, my short answer, yes, we need to extend ECDC capacities, for sure. Now, situation is on the way. EMA was strengthened after pandemic, ECDC was strengthened after pandemic, HERA was established. But those three agencies now need much bigger support and much more, competences and much more financial support, and of course also labor shortages to be addressed. ECDC is weak at the moment, very weak. If you compare CDC in the United States and ECDC in Stockholm, uncomparable. It's a huge differences. And of course, you know very well that we need to have a real agency, but now is only way is ongoing. We have no comparable data in the EU. When we are speaking about tuberculosis, you know that such was estimated. One country speaks about 7%, another about 3%, but we have no aggregated, standardized data because no one agency is collecting data till now. This is a problem. I can stop here, but I am big fan to have much more strongest ECDC, and from our group, we propose to establish much broader agency which can, unite those three agencies, because we need to keep one, if we are speaking about one health approach, we need to have agencies which are able to provide data based on one health approach.
Did we have any other final remarks on ECDC? I think you've covered it. Okay, I think, can we get one more round of applause for our panel, please? And then I'll hand over to Mark. Thank you very much.
I would like indeed to thank everybody, the panelists, but also the public, the questions online. And for me, indeed, just as a closing remark, we heard indeed somewhere kind of a catch-22, and I share Paul's sense of frustration as well, somewhere that we as civil society, we as medical doctors, we see indeed the reality of the patients themselves. And on one sense, on the other, indeed, there is the reality, the hard reality that health is a member state prerogative and responsibility. But I think we can do more. And I think that's why we have decided as a first step to have this panel and also sharing this online. I think we can do more because first we need to create this awareness. And I think it's our responsibility, individual, collectively, as an organization, as a citizen, and also as a member of parliament and a member of commission, to try to raise and convey this message. And that's why we invite you again, please spread the message, please spread the information. If all of my colleagues from the civil society and other countries could also help distributing this message, reinforced maybe also by your own experience, and indeed to try to put this on the political agenda at member states. But here I would like also to ask the European Parliament to push this up to a higher level, and we are happy to come and share our expertise, to come and share our witnessing with other colleagues as well. We need indeed, first and for all, to put it on the forefront. And don't know all the channels that exist, but I definitely can assure you that we are very happy and supportive to provide all the information that we see on the field in name of our patients that we try to treat. It is not so much about the patient, it's about whole of Europe indeed. It's about an own health in Europe. There is also indeed, I heard several other comments and ideas forward. It's also about indeed some rules and regulations that needs to be strengthened and can be looked into. And we are going as MSF, but also I hope with other colleagues from other civil societies to address this at ECDC or at EMA as well. One of the bottlenecks is the WHO pre-qualification that is not accepted. And I feel here as well, I think we need to try to push this forward. We need to try to absolutely bring this at the political agenda with all the difficulties that exist, but we are bound together. We have one common enemy. I think we cannot afford to push the responsibility to another level. Let's work together. And that's my biggest invitation here, my biggest, I would say, plea here to the policymakers, to the civil societies, to the patients, to the clinicians, the doctors, the nurses of the patients, and so and for all, as well with our colleagues of the Commission, let's try to find a way to address this at the highest political level where we need, and let's work together, brainstorm together how we can put this further and address, and hopefully have a second Ministry of Health meeting this year or next year in Europe, here in Brussels, or anywhere else in the European Union that can address specifically the state for tuberculosis and treatment of tuberculosis, prevention of tuberculosis. And as MSF, we would be very happy to collaborate with several other partners. Thank you very much. And so I would like indeed, for the people online, you invite you to contact us for further information or collaboration. And the people here in the room, you're mostly welcome to join for a soft drink and a snack. Thank you very much.